Hello, everybody. It's my pleasure to continue our journey for the early detection and screening programs. And today we will discuss the gynecology malignancy. In the United States, each year we have 71,000 women are diagnosed with, and about 27,000 women die from gynae cancer. In global figure and by global cancer estimation, we can recognize the cervical cancer is the first rank cancer-related incidence, and uterine cancer is the second type of the gynae tumor incidence, followed by ovarian cancer, vulvar cancer, and vaginal cancer. If we can consider and figure cervical cancer as a part of the uterine, or the cervix is part of the uterus, we can recognize the presence of both is merged together as cancer-related incidence of gynae tumor about 64%, while cervical cancer alone is considerable 43% related incidence and 30% for the uterine body as the incidence of gynae tumor. Endometrial carcinoma, by estimation, 68,000 new cases of endometrial cancer will be diagnosed in the United States in 2026, making it the fourth most common cancer in women. We have a modifiable risk factor, especially the prolonged exposure to high estrogen level, which is considered the strongest factor. It could be related to the menstrual history as early menarche and late menopause, and hormone replacement therapy. Taking estrogen alone without progesterone during menopause significantly also increases risk, and nulliparity is increased risk compared to having at least one pregnancy. Medication by the use of tamoxifen to treat breast cancer, which act as estrogen in the uterus. The non-modifiable risk factor is actually related to the genetic factors, inherited syndromes, most notably the Lynch syndrome or hereditary non-polyposis colorectal cancer, which is significantly increased the risk, and the age. Most cases are diagnosed in women over 50, especially 65 to 69 as a median age for cancer diagnosis in endometrial cancer. And we have other factors like type 2 diabetes, high fat diet, physical inactivity, and personal history of breast and ovarian cancer and post-pelvic radiation. Cancer staging actually is a mandatory point at the clinical diagnosis, and this is considered to be the key factor for decision making and treatment. Treatment guidelines ought to be applied upon the proper estimation of the cancer staging. In stage 1 disease, we have the disease or the cancer cells are inside the uterus only, while in stage 2 disease, we have the cancer spread to the cervix. In stage 3 disease, cancer spread to the lymph nodes, ovaries, fallopian tube, and or vagina, and in stage 4 disease, cancer spread to the more distant organs. Thus, we can consider the early stage disease in stage 1 and stage 2. Stage 3 also could be treated surgically with radical hysterectomy and surgical removal of cancer with a safety margin and the proper estimation of the lymph node. Sometimes we go for mapping of this lymph node by sentinel mapping to detect the diseased one and surgical removal of all. Sometimes we go for partial hysterectomy or just surgical removal part of the uterine body or added to the cervix also, while in stage 4 disease, surgery is too much difficult. We go for palliative chemotherapy, radiation therapy to the systemic control. Little bit we will go to discuss the cervical cancer before the treatment guidelines for all. Cervical cancer is a largely preventable, slow developing cancer of the cervix. The cervix is the lowermost part of the uterus, and we can consider the uterus and the cervix together responsible for 60% of the cancer-related incidence in gynae tumors, and about 43% is if it is considered alone and the gynae malignancy incidence. Okay, cervical cancer by global incidence rate, it is about 40.1 per 100,000 women, and the highest burden region in Eastern Africa, Southern Africa, and Middle Africa have the highest incidence rate ranging from 31 to 40 per 100,000. Okay, cervical cancer by global incidence rate about 40.1 per 100,000 women, and the highest burden region Eastern Africa, Southern Africa, and Middle Africa have the highest incidence rate ranging from 31 to 40 per 100,000 population. Okay, risk factors for the cancer cervix considered to be important, especially this is widely prevented, like human papillomavirus, as a persistent high-risk human papillomavirus infection is a primary cause, with over 85% of the cases occurring in women. Smoking increases the risk in developing cancer, cervical cancer, and immune system deficiency, as weakened immune system make it harder to fight human papilloma virus. Reproductive factor like long-term use of oral and contraceptive or giving birth to many children. Symptoms or complaints of abnormal vaginal bleeding. This is the most common symptom, occurring in about 90% of cases. It includes bleeding after menopause, spotting between periods, or unusually heavy menstrual cycles. Abnormal vaginal discharge, a non-bloody, thin white or pink discharge that's watery or thick may occur. Pelvic pain or pressure. Pain in the lower abdomen or pelvis, which may occur during intercourse, can indicate advanced stage or growing tumor. Unexplained weight loss, losing weight without trying, and difficult or painful urination as changes in bladder habit or pain, particularly if cancer has spread, can occur. Cervical cancer staging also. In stage 1 disease, actually this is um, more or less detailed the stage, and we have a detailed staging system as it is considered to be applied upon the horizontal spread, the depth of invasion. We can consider the staging related to microscopic invasion by millimeter in depth and invasion in horizontal spread. Why? Because we can go for a little surgical procedure by use of cone and removal of just a smaller part of the cervix and not all the cervix. Thus, the staging actually is too much detailed, but in stage 0 and stage 1, we can comprise a preclinical stage of the cervical cancer. It is not visible even by colposcopy. It is less than 4 centimeters. It has microscopic or invasion in 3 to 5 millimeter in early stage, 3 to 7 millimeter after, and the horizontal spread also. Once this is clinically visible, beyond 4 centimeters, it is not the time of detection. It is not the time of screening. Thus, in stage 0 and stage 1, this is comprised a preclinical stage of cervical carcinoma in which cervical screening and colposcopy play an important role, which go with millimeters only. In diagnosis, normal are usually symptomless. The cancer is not visible within the naked eye and can be detected only by cytology. The cervical cancer staging is stage 1A carcinoma. This is microinvasive disease and usually detected on cytology in asymptomatic women in the background of widespread of cervical intraepithelial neoplasia 3. This is intraepithelial changes in the cell without presence of visible disease by the naked eye and only detected by cytology. In 1A1, the carcinoma are defined as invasion less than 3 mm in depth or 7 mm in width. The smallest lesions are described as early stromal invasion. While in 1A2 carcinoma, this is between 3 and 5 mm in depth and less than 7 mm in width. These carry a slightly higher risk of lymph node involvement. In stage 1B1, cancers may either be symptomatic or asymptomatic and detected by screening. Stage 1B2, more than 4 cm, and stage 2, stage 3, and stage 4 disease are usually associated with clinical symptoms such as postmenopausal or postcoital bleeding. Postcoital bleeding actually is highly specific to the cancer cervix and the presence of invasive disease. Usually we go in uterine cancer as postmenopausal bleeding with prolonged exposure to estrogen for a long time, nulliparity, age actually more older than the cervical cancer. While in cervical cancer, we go for clinical diagnosis symptoms, or the main symptom is a postcoital bleeding and the presence of previous exposure of human papillomavirus, or even in younger age than the presence as it occurred in uterine cancer. Thus, postcoital bleeding is highly specific to the presence of cervical cancer, and it comprises a clinically invasive stage of the disease, and survival is directly related to the stage. As 5-year survival is 100% for stage 0, 85% for stage 1, 65% for stage 2, 35% for stage 3, and 7% for stage 4.